Thank you everybody for joining us today. I'm Michelle Gady. I'm the president and CEO of Atrómitos. We are a boutique consulting firm headquartered in Wilmington, North Carolina, with team members in Metro DC, Connecticut, Illinois, and Tennessee. We work primarily with companies in the health and human services industry, helping them navigate change. One of our service lines is policy research and compliance support, which brings us to our topic today, and our presenters, Tina Simpson and Peter Freeman. Tina brings over 15 years experience in health policy and administration to her role as principal at Atrómitos. She began her career as an assistant attorney general with the North Carolina Department of Justice, representing what was then the Division of Medical Assistance and the Office of the State Treasurer. With over a decade's experience in leading adaptive change across various organizations, Tina recognizes that one of the most common challenges is resisting the temptation to apply technical solutions to adaptive challenges. Tina's strength is not only in effectively identifying adaptive challenges and strategies to address them, but working with stakeholders to maximize acceptance by aligning adaptive change within an organization's core values and missions. As a certified healthcare privacy compliance professional, Tina is proficient in strategically aligning both legal and business risks. Peter Freeman joins us today from Chicago. He's a senior consultant with Atrómitos, bringing 15 years of healthcare operations experience. He has worked in 3 different healthcare markets, including Illinois, New York, and North Carolina, helping providers understand state and federal requirements and then strategizing how to improve their performance within provider networks. Prior to joining Atrómitos, Peter was the vice president with the North Carolina Community Health Center Association, supporting the FQHCs in their medical home network, IPA, and ACO. Tina and Peter, thank you for your presentation today. Tina, you want to go ahead and get us started?
Yes, thank you for that introduction, Michelle. So I'm so pleased that you all were able to join us today. The topic is a revolutionary recalibration, HIPAA and interoperability. I am ONC and CMS this past year have promulgated 2 new rules that create a positive duty for certain actors to share data across existing systems and to create standardization, technical standardization to facilitate that kind of exchange. This represents a fundamental and abrupt change to the HIPAA regulatory framework, which, as you are all probably very aware, up to this point have really prioritized data stewardship by covered entities, focusing on privacy and security. We have a very dramatic title, a revolutionary recalibration. And one thing that I want to stress from the beginning is this is not just, these new additions to the regulatory framework are not just revolutionary because they are a departure from the past 24 years of, regulatory updates and tweaks to HIPAA, but they're also revolutionary in that it reflects a return to HIPAA's original intention, which was to make data more portable across health systems. Interoperability has been at the center of HIPAA from the beginning, and that is an origin that is not fully appreciated or certainly hasn't really been practiced throughout its history. And these new rules represent the first opportunity to return to that in a meaningful way. So if we could turn to the next slide, Peter. Yes, so our objectives for this are going to be, first, to outline the new duties and opportunities created by these final rules. These rules, as I mentioned, come from 2 different regulatory agencies within DHHS, and they apply based on different stakeholder categories. So we're going to take the time to go dive into the rules and outline, what is going to be required of different stakeholder groups and what you need to prepare for. We're going to, secondly, explain why these rules are foundational to integrative care delivery and value-based care models. So in short, why interoperability is the name of the game, for quality of care generally and value-based care delivery innovation specifically. We can't build a new system of care without this key cornerstone. So this is a very important change. Third, we're going to provide insight on the practical application of these rules in both clinical and administrative settings. And then finally, we're going to discuss concerns on the final rules as they relate to patient privacy and what stakeholders can do to ensure that patients have the information that they need in order to exercise their right of access in an informed way and to protect themselves. Next slide, please. So in order to do this, let me outline sort of the agenda for today, because we've got a lot of topics to cover. We're going to start with sort of an introduction to HIPAA. I know everyone loves HIPAA, and that's why you're here today. But we're going to very briefly give some context to the regulatory framework as it exists now. And then my colleague Peter is going to dive into some of the unintended consequences that HIPAA has had a chilling effect on interoperability, and then why interoperability is so important. After that that sort of setup, we're going to look at sort of the rules themselves. I will be outlining the ONC rules, which primarily deal with EHR certification and criteria for maintaining that certification, as well as the prohibition against information blocking. And Peter will be discussing CMS's rules, which regulate Medicare, Medicaid, and CHIP, so rules that use the government's authority as a payer. Then we're going to bring it back to HIPAA, what it means there, and some conclusions, including a discussion on concerns that this creates, that these rules, which focus on improving patient access to data and allowing patients to direct data to third-party app developers, such as the various phone apps, for care management and other self-management tools, and how that can be, there are legitimate concerns that is sort of avoiding of privacy protections, and how, while this is a necessary first step in sort of recalibrating the balance between privacy, security, interoperability, and efficiency, this is not a final step, and we need to be aware of some of the dangers of swinging too far in either direction, and being able to exercise our responsibilities in an informed manner. And then we will reserve some time for questions and discussion. I will note from the offset, this is a lot of material here, and I believe that we have a little bit of time if we go over for a little bit of discussion, but we will try to keep a quick clip throughout this. Next slide, please. So we're going to go straight into HIPAA. Next clip. It's kind of hard to describe HIPAA in just one slide, but this is our best attempt at it. HIPAA regulates the manner in which protected health information can be used and disclosed by covered entities and their business associates. It has three primary purposes. That is to make HIPAA, the health insurance, portable under ERISA, to create a framework for a nationally standardized electronic billing platform, and then to prevent fraud, waste, and abuse. And that last one is an addition from the 2010 Administrative Simplification Rule. You'll notice in none of those three things is the primary purpose, the creation and enforcement of a privacy standard, although that is a significant and fundamental output of it. Because HIPAA does create and enforce a baseline right of privacy. One of the most important things about HIPAA you need to understand is what is protected under HIPAA. It covers protected health information, PHI, which is defined as individually identifiable information that is created or received, maintained by a healthcare provider, health plan, or other covered entity, and that relates to the physical or mental health or condition of an individual. One thing that I want to point out here is that HIPAA thus creates sort of a sectoral lens or industry lens for health data. What is protected is a specific data because it is maintained or held by a covered entity. So in order to determine whether HIPAA applies, you have to know, first of all, what is the data involved, who holds the data, who is responsible for it. This creates a duty of stewardship and holds covered entities and their business associates responsible. Next slide, please. So before this presentation, I asked you and the LinkedIn universe to share your top 3 words that you associate with HIPAA. And I did this in part to test a hypothesis, and that was that interoperability or ease of exchange was not going to feature anywhere in those words, and that did play out. I will say we have the outcomes of that survey here. Compliance, privacy, and confusing get top billing. That probably is not a surprise to many. I think compliance and privacy are self-explanatory, and confusing is legitimate. HIPAA is a very complex regulatory framework, and it is particularly complex because of the fact that it applies that sectoral lens to determining what data is protected and what standards apply. So anytime there is while HIPAA might have sort of black letter law in the context of thou shalt not disclose protected health information unless there's patient authorization, there are a lot of exceptions to that. There are a lot of prior to any disclosure, there is a necessary evaluation and analysis of that specific data. Is it subject to HIPAA? Is it PHI? Is there an exception? And that can be, as some of the words here described, overwhelming, stressful, confusing, unclear, and a barrier to ready exchange. There's another word here that I want to point out, and that is punitive. HIPAA can strike fear in the hearts of many because it is perceived as a strongly enforced, it is a rigorously enforced privacy right. It is heavily scrutinized, and there are significant penalties associated with non-compliance. So I also, while compliance, privacy, and confusing definitely get top billing, I also want to point out stressful, overwhelmed, punitive, legal concerns and challenging as being something that is also commonly associated with HIPAA. If we could go to the next slide. I'm going to jump a little bit into why punitive, stressful, and all of those other things feature in this when you would think of HIPAA. HIPAA enforcement, as I mentioned, is strict. It is primarily enforced by the Office of Civil Rights in HHS, which has the authority to levy civil penalties and corrective action plans for violations of the privacy, security, and breach notification rules. The primary purpose of these penalties is to be a deterrent. Consequently, these fines are substantial. While there are a ceiling to the fines, I think off the top of my head, I believe it's $1.5 million per year per violation. Those things can be cumulative. And frequently when there is a HIPAA violation and a HIPAA investigation, that is not a question of a single violation, but of multiple incidences, frequently covering many years. So the penalties are significant and are specifically designed to make people think twice and to raise the cost of violation to one that encourages compliance. These penalties are tiered into 4 categories, which broadly captures the range of intent or recklessness associated with the violation, the severity of impact to the individuals, and other aggravating or mitigating factors. Again, this is another reason why HIPAA is an area of gray. It's not a question of one act is always going to be associated with this set amount. Penalties range from $100 per violation up to $50,000. And there's a lot, that's a very pretty broad variance. And things such as the size or sophistication of the covered entity or business associate that is involved in the violation, the corrective steps that are taken to correct it, all play a part in what the final levy is. So again, HIPAA crystal ball, nothing is necessarily determinative. There's always an analysis. There is also individual criminal liability where there's a violation of patient privacy where it's done for financial gain or with malicious intent. And then additionally, in addition to the cumulative effect of penalties that OCR can levy, HITECH in 2010 allows states to also pursue additional actions against violators. This includes attorney's fees. Next slide. Next slide, please. Thank you. So again, this brings us back to our word association. HIPAA can be a tangled mess, and that is the reason why it can be perceived as overwhelming, confusing, and punitive. And that is sometimes baked in the fact that it does, while it is a simple thou shalt protect patient privacy and not misuse it, not misuse their data. There are so many iterations, and we generally operate in the space of the exceptions. Further confounding this is the fact that there's no real standardization of security standards across organizations. So HIPAA, this level of security that needs to be in place for any covered entity is reflective of the size of that organization, sophistication, and their own operations. So HIPAA is a very unstandardized, health data is a very unstandardized area. And that is one of the reasons, one of the things that these new rules seek to address. So I'm going to turn this over now to my colleague, Peter, who will talk about why why these concerns how these concerns have implicated data exchange in the past.
Thanks, Tina. Good morning, everyone. So I'm going to spend a couple of minutes talking about, as Tina mentioned, the unintended consequences of HIPAA coming predominantly from the provider side. There is sometimes a division between how those of you who look at HIPAA from a regulatory stance and those of you who look at it from a programmatic stance do not always align on what is actually HIPAA related, what is just a barrier in the healthcare industry. So we're going to try and connect those dots this morning. So first, a quote from CMS Administrator Seema Verma, acknowledging that technology and the sharing of data really is underpinning the entire movement into APMs, value-based care. If we don't have open data sharing, if we don't have effective privacy and security, we can't keep our patients healthy because we can't very comfortably share data. We can't know all that we need to about our patients in order to keep them in a state of health. So this is coming from an address that was done last year at HIMSS that Administrator Varma did. So there's pretty high recognition that this is something that the government wants to see moved forward. But let's level set a little bit. So I think for a lot of people, if we talk about trying to take care of patients, we can agree that in healthcare, interoperability is somewhat the name of the game. Healthcare is a very data-driven industry. It requires data interoperability. And for the purposes of our talk this morning, we're really focusing in on that operability as the ease with which a patient or their provider can access and use a patient's healthcare record. Over to the right, you can see healthcare. This is obviously a very short list of how and where data is used in the healthcare industry. But if you think of things like value-based care arrangements frequently include measures related to hospital-related services, and those contracts are very often placed on primary care providers. So there needs to be some sort of ability for primary care and hospital systems to communicate and share what patients are getting services and what level of care. When we think about things like clinical decision support, these are systems that are put in place to help providers take the full extent of patient data and make evidence-based decisions on how to best provide and prescribe treatment for any given condition. With incomplete patient health data, there is a risk that those clinical decision support systems are unable to give the most accurate or most up-to-date analysis or picture of what the patient is needing, which could alter erroneously, potentially, what treatment is prescribed for them. Treatment modalities, medication regimen, obviously all of that requires really fluid data exchange, specifically for medication regimen, not just to know what the patient is already on, but what their dose is it an appropriate dose? Are there any indications that two medications might conflict with each other? And then care plans in general. This speaks more to a patient's ability to access care. As we move farther into the value-based care arrangement, there's more emphasis being placed on patient engagement in their own treatment, which means patients need to see what's in their care plans in order to agree to the treatment of care. So in the healthcare, I think this is a surprise to no one. We are widely reliant on data. However, the infrastructure upon which we share that data is highly fragmented. As mentioned on the last slide, many patients see providers across systems, across practices, across entities, across levels of care, across tax ID numbers. I mean, you name a different type of system, a patient probably interacts with about 4 of them. So they're not all collaborating in the same way. mergers and acquisitions, which is happening quite frequently in the healthcare industry now. And there was actually, as a side note, an analysis done earlier this year that said as we move into value-based care, people anticipate mergers and acquisitions to increase in frequency in order to build sustainability of the healthcare infrastructure. So we can expect more mergers and acquisitions to come. But just because two entities have merged together does not mean that they become a single unified entity. They could have any number of legal arrangements with each other, and those different legal arrangements have different legal access points to data. And then if you think about networks like IPNs or clinically integrated networks, some of them have multiple EHRs. And that's just the EHR. Some of them have data analytic platforms and care management platforms. Some of them have community-based referral systems. So you could have an innumerable number of platforms at play within the same provider, and making sure they all speak to each other can be a challenge. So the data interoperability infrastructure is highly fragmented, and HIPAA doesn't always necessarily help us solve those problems, and sometimes it actually causes the problems. Privacy and security concerns, as is evidenced by the word bubble that was presented earlier, drive a lot of concern for HIPAA. People are very aware of what they need to do to protect data, or want to be well aware of what they need to protect data, so they put that at the forefront of exchanging patient information. Providers, I think not erroneously so, defensively interpret HIPAA for self-protection. They want to make sure that if they are sharing data, they are doing so in a way that is protective of their patient as well as themselves, which sometimes create unintended barriers. And then there's sometimes a limited alignment of interests and intents within the market. As we think about, and we'll talk about an example in a minute, if we think about something like an HIE, those have been notoriously hard to stand up across states and across regions. But for those HIEs that have been successful, is there a way to monetize that? Is there a way for them to leverage that data that is potentially shared in a secure, HIPAA compliant way that is beneficial to them? Because it does take a lot of work to stand up. That is not aligned with the primary care providers or non-participating health systems that need access to that data, those data, to take care of their patients. So the way HIPAA is constructed sometimes does not help us actually do the interoperability that was one of the original intents of the law. So what are some of these unintended consequences? These are just some of them. I want to emphasize they're not all of them, but in sort of three main buckets, there are some ways to think about it. One is, I think, no surprise, lack of access to data. We've talked about it quite a bit this morning already. There is a need for data sharing agreements, which can sometimes be legally cumbersome and confusing. You can have a complicated legal process in order to set up those data sharing agreements, both with your EHR vendor or your platform vendor and with the health system or the provider who is owning the data. Very, very rarely does this legal process include the patient who the data are actually about. So you have the complicated legal processes. Sometimes these set up erroneous firewalls, depending upon how the viewpoint of who owns the data comes into play. You could have access to data, but that does not mean you have access to all the data you need, or that you're able to analyze the data in a way that you need, or that you're able to request access to or data to be sent to providers who need it. And then there is limited patient engagement. A lot of the work being done right now when we talk about access to data is from provider to provider, but we also need to start thinking about how do patients get access to their data. Inability to innovate has been seen as also an unintended consequence of this lack of data sharing. As we saw from Administrator Varma's quote earlier, she really does see the sharing of data as driving innovation. If you don't have good data sharing, if providers don't feel comfortable or feel they have a mechanism to share these data, they are probably going to underperform on contracts that are transitioning into value-based or alternative payment method arrangements. So we're seeing limited progress on the move into value-driven care. If providers are finding themselves unable to perform on HCP LAN 1 or 2 value-based care arrangements, they're probably less likely to move into higher risk-bearing contracts, HCP LAN level 3 and 4. So we're moving very, very slowly, if at all, into things such like a total cost of care arrangement, where a provider really does have a lot of flexibility to care for the patient in the way that they know needs to happen. And also it sometimes prevents a provider from accurately staffing for the care that is needed. If there's not a full picture of what the data is saying, they may not be staffing up for services their patients need because they may not know that their patients are engaging in certain types of care. And then lastly, we also want to look at, oops, apologies for that, I went too fast. The systemic challenges are looking at, back to your value-based care comment, does that mean that we're trapping providers between a fee-for-service and value-based care world? We're asking them to move into value, but not giving them the full suite of tools they need in order to fully get out of fee-for-service. We have, as we talked about earlier, misaligned incentives between the haves and the have-nots. So the haves could be the people who are owning the data, the HIEs, the EHRs, sometimes your larger health systems, and the have-nots are frequently providers or health systems that are independent and trying to access the full suite of services their patients are interacting with. And this really also does get down to preventing whole person care. Without access to all of the data and all of the services that our patients are interacting with, it is very hard to fully take care of your patient holistically. So just a couple of quick examples. The primary care and value-based care example, primary care providers are transitioning into value-based care arrangements. They often have hospital-related quality metrics. These are things like ED admissions, readmissions. The problem is that without a good sense of interoperability, relevant data is not shared between the hospital and the primary care providers. Sometimes your solutions, if and when they are agreed upon, include those legal arrangements that can be complicated or over cumbersome. They can include unaffordable data exchanges between EHRs and care management platforms, or the provider could just end up with no data whatsoever. The outcome of this is that you have, as we mentioned before, limited progress on value-based contracts, and we're stunting the transition into higher levels of risk and more advanced APMs. Another example we wanted to throw out there, and I believe we'll revisit this later, is the North Carolina Health Information Exchange. The state has had multiple attempts at a statewide HIE. Depending on your viewpoint, there are two ways that this problem existed. The first viewpoint is that the state could not stand up its statewide HIE, so regions and hospital systems came together and created their own. Or the flip side is that health systems would not participate in the state HIE because they already had their own data system transfers. Either way, the problem was that you weren't having a very well populated or utilized HIE infrastructure. So right now, the North Carolina state legislature has required that providers who receive state dollars for healthcare services must submit data into the HIE to start creating that robust exchange and flow of data. The outcome of this so far is that while providers are submitting data into the HIE, they are not all leveraging it, which means there is still a lack of a bidirectional flow of data being used in order to take care of our patients. We're also seeing that we're still seeing some exorbitantly priced connectivity costs between systems, providers, EHRs, the state, et cetera. So again, we put these out here as a way to start connecting between the dots between how people think about HIPAA as a regulatory issue and how providers are seeing it on the ground, because I would say in rare cases when I was working with providers, did I have an EHR vendor or a health system or a provider coming to me and saying, this is a HIPAA issue. We were seeing it pushed as a security issue, a cost issue. So we just wanted to connect the dots for you on how this can be translated into actually caring for our patients. Tina, you're on mute.
Thank you, Peter. And we're throwing a lot of information at you. I just want to encourage everyone, we will take questions at the end. In the interim, if something comes up, please feel free to put that in the chat function. We will collect those and answer those at the end. So with that long introduction, we're going to now look at the rules themselves. The first set of rules comes from the Office of the National Coordinator for Health Information Technology and is developed under the Cures Act of 2016. The Cures Act was primarily focused on the pharmaceutical industry and drug regulation, but there was a small section that defined and prohibited information blocking. Information blocking is something that you probably have, if you are practitioners have encountered, at least in practice, such as, where there's an entity that doesn't give access to data that one has an appropriate use for. The statute also directed the Office of National Coordinator of ONC to develop rules to regulate conditions which HIT developers, specifically EHR vendors, can participate in federal programs. This is built particularly around the idea of governing and protecting against information blocking and standardizing technical interoperability across disparate systems. And then finally, authorizing civil monetary penalties as an enforcement mechanism against specific actors, namely HIT developers, who engage in information blocking. The objectives of these rules, very broadly speaking, is to maximize innovation and transparency in healthcare. The idea is that with greater access to information, as HIPAA, as Peter outlined, you are able to drive greater efficiencies. For patients, this is operationalizing in many ways an existing right of access that is provided under HIPAA. This improves the quality of care in the context that patients are able to review their record, make corrections, be more engaged in the care, and select partners in managing their own health conditions, and be more informed consumers. And that will the premise is that will drive greater efficiencies and quality. For providers, it's to make this whole process a little bit easier, to reduce the barriers, whether they are technical or the infeasibility practical barriers that Peter described. Additionally, there is the intention of promoting competition across software. Anyone who has gone through an EHR implementation knows that it is a very big overhaul, a big undertaking, and once you have it, you tend to stick with it because it is hard to transfer between different systems. This specifically, one of the big conditions of this rule is that it requires EHR vendors, in order to participate in federal programs, to export data without cost, where there is a change in software providers. So that is intended to improve competition and enable providers to be more savvy and liberated consumers. For health IT developers, some of the other on the other side is we want to minimize the cost of these API portal developments and protect their IP. I think I should probably first start here with describing what APIs are. And I am very untechnical, so this is going to be very basic since we're going to be referring to this throughout this presentation. APIs are essentially the ability to interface between one disparate health system and another. So it's extraction, and it's a vector for the exchange of information. So insert that whenever I reference APIs. Next slide, please. The final rules do many things, but generally speaking, there are three broad domains of activity. The first, it updates the criteria for EHR vendor certification. And as I mentioned, this is an absolute necessity for any vendor that wishes to be competitive, because otherwise providers can't bill for Medicaid or Medicare unless there is this certification in the software. It creates requirements for maintaining that certification. So there is going to be a monitoring and auditing system. It's not a one and done, but the vendor providers are going to have to continue to demonstrate compliance. And this is also important because since it recognizes that interoperability, including technical standards, that this is a flexible and iterative process, and one that is going to be monitored by ONC. And then finally, it puts teeth in the ban of information blocking. It's one thing to say you can't do this. It's another in order to have a mechanism that will enforce that you mean business when you do violate that. And this includes civil penalties, specifically for EHR vendors, HIT developers, and health exchange networks and health exchange and HIEs. Next slide. ONC primarily regulates HIT developers. So there are three categories of actors who are regulated by this rule, and primarily it is HIT developers. You will notice that the civil penalties, et cetera, and the conditions of participation in this program really hit the EHR vendors, but it also applies to healthcare providers. And healthcare providers here include, hospitals, health systems, physicians. It's a broad catch-all. So it's important. Different responsibilities and different penalties are associated with where you fall in these 3 categories. I'm going to very quickly, the EHR certification process, we've got some technical, it creates some technical standardization. It institutes the US Standard Common Data Interface, or probably US CDI standard, moving this from the common clinical data set. This is significant. I would say that this is one of the most important components of the EHR certification process. The common clinical data set, which is the current standard for data exchanges now, lacks 50 elements of what we define as true interoperability. It doesn't include a lot of clinical notes. US CDI essentially, because it includes case notes and the like, it really reflects essentially the entirety of a patient's record. So whereas under the common clinical data set, you sort of get kind of a broad picture snapshot of a person's health, this is intended to be longitudinal and comprehensive. Again, for certification, you have to demonstrate that you're capable of exporting EHI, and must create standardized APIs for that purpose that enable the free or very low, or free or population queries, low cost exportation of that US CDI EHI for both single patient queries as well as population aggregated queries or bulk data. It also includes no privacy and security transparency attestation. This includes encryption, authentication, and multi-factor authentication. Next slide. The things that I would want you to take away is that, again, we're moving from the common clinical data set. We are expanding what data is the relevant exportable data set that people are going to be, that you are going to have to be able to exchange readily and easily, and that you're going to be judged on. It's going to be that US CDI change standard. And then additionally, it's requiring technical updates to enable those real-time exports of EHI. Now as I mentioned, it's not just a one and done. There are going to be conditions of maintenance. So again, you are having to attest that you can't engage in information blocking. You're going to have to provide assurances to that effect. And that includes retaining records for a period of 10 years, demonstrating your compliance on this, and actively attest to that. You're going to have to engage, you cannot prohibit or restrict communication regarding the usability of its health IT, the interoperability of the technology, or otherwise sort of mislead people about data interoperability and functionality. You can't kind of create barriers to patients or other people utilizing those APIs. You're going to have to demonstrate the application APIs themselves, and there's going to be real world testing with ONC as to those, the functionality of those APIs. And you're going to have to, on a 6-month basis, attest to this, and it's going to be monitored. And in the future, there's going to be enhanced reporting criteria submission. So I think that through all of these, the thing I'd want you to take away is that this is a iterative evaluation of how effective the technical interoperability is in practice, and the absence of practices by the EHR that could impede patient access or that exchange of information. So we've talked a little bit about information blocking. It is defined super broadly and helpfully by statute as a practice that, if it's a covered entity, except as required by law or specified by the Secretary of Health and Human Services, as a reasonable and necessary activity is likely to interfere with access, exchange, or use of electronic health information. That is so broad as to not particularly be helpful. So these rules are very important in that they provide a little greater clarity on this. And it's a little bit like, you know it when you see it, to quote a Supreme Court justice in a past case. So it's sometimes easier to say what it isn't as opposed to what it is. So ONC has instituted sort of 8 safe harbors or exceptions. And you want to, and created sort of a on your own head be it if you don't fall within these still pretty broad exceptions. And we're going to go on that in a moment, but just want to also state that when it comes to information blocking, as I mentioned, there are civil penalties. These civil penalties, though, only apply to health HIT developers, HIEs, and HINs. Providers by statute were explicitly excluded from that. However, there is, as we will discuss, the space and intention to impose other appropriate disincentives or scrutiny. Next slide, please. So let's look then at the information blocking exceptions. So there are 8 exceptions. There are those that fall in the failure to fulfill requests. The first is preventing harm. It's not going to be information blocking if you engage in a practice that is made in the intention of you reasonably believe are necessary to prevent harm to a patient or another person, where there are certain conditions. And these key conditions are, it has to be a reasonable belief that it will substantially reduce risk of harm. The practice must be no broader than necessary to prevent that harm. The practice must be at least tailored to the type of risk, the type of harm, and implementation. So it has to be very, very narrow to very specific circumstances. That narrow tailoring is going to be scrutinized. And if you're saying that you're not providing information because preventing risk of harm, be sure that it is as you're using a scalpel to get to that risk of harm, as opposed to a butcher or cleaver. The next is the privacy exception. It's not a information blocking if providing that information is in violation of federal or state privacy laws. The security exception is, if you have a reasonable concern regarding the security of EHI, it must be, again, very narrowly tailored, and that narrowness is going to be heavily scrutinized. It must be directly related to safeguarding that specific, the confidentiality, integrity, or availability of that information, tailored to a specific risk, and implemented in a non-discriminatory and consistent manner. You're going to want to tie that back with sort of your organization-wide risk assessment, and you want to be able to demonstrate that this is something that you are aware of on an organization-wide level and applying in that consistent manner. Infeasibility. So it's not going to be information blocking if you are not able, if that request is unfeasible, assuming uncontrollable events, segmentation where you can't reasonably segregate the requested EHI, or other circumstances which are left kind of broad. But I think that unfeasibility is going to be a very challenging one to meet all of those conditions, since a lot of the purpose of these rules is you're going to have to standardize and provide access. The health IT performance exception. It's not going to be information blocking if it's necessary to make it temporarily unavailable, or it degrades performance of the network. So again, this is over very short periods of time, and more to capture sort of those unavoidable downtimes. These are discrete instances, so it's not going to be information blocking if your network goes down because of you're responding to some security incidents, for example. There is also exceptions that involve the procedures for fulfilling requests to access exchange PHI, the content and manner exception. This means that a actor must can limit the content of its response to the information requested. It doesn't mean that you have to go beyond what is requested. I think that this next one, fees, is going to be particularly important. It's not necessarily information blocking to charge fees for the use of an API. However, there's going to be a lot of scrutiny onto the calculation of those fees. Those fees can't be more than what the cost of developing the API is, spread out over a period and over a population with a very reasonable profit margin. This is, I think, the area that's going to be scrutinized most scrupulously. You are going to, these fees are going to have to be based on objective and verifiable criteria, uniformly applied, be reasonably related to the costs, and not be based on, sort of competition concerns. So you can't charge your competitors more for switching to another EHR software if in certain circumstances or used in that way. You can't charge for individual access. You can't there are certain instances where you cannot charge for downloading of EHI. This is where a lot of the meat is going forward. There is, of course, the licensee exception. This comes back to wanting to also protect the HIT developers' right, IP, their investment. So there are going to be incidences where you can license negotiations where there's going to be scope of rights, reasonable royalties, non-discriminatory terms, et cetera. But similarly, as with sort of the patient access and more individual level access, it's going to be have to be tailored and universally applied. Next slide, please. OIG has issued sort of guidance on calculating civil penalties. Again, these are significant. They're up to $1 million fine per violation. Like with other regulations, they're going to be assessed on an individual basis, looking at the nature and extent of information blocking, the harm resulting, and the number of and sort of how long that is out there. Next slide. In its guidance, OIG has sort of broken down how they're going to calculate the number of violations, as this is going to impact how big the fine is. There are going to be practices where a single action constitutes a single violation, regardless of the fact that it may implicate numerous patient records. And we have one example here. A healthcare provider notifies its developer that it's intending to switch over to an electronic health record, to a new software, and they need to have all of the patient data extracted, uploaded to that new provider. Their failure, if they refuse to do that without charging a fee, this would constitute a single violation, even though it has multiple data points are being restricted. So conversely, if we can look to the next slide, there are examples where a single policy decision can have a cumulative effect and constitute multiple violations. In this instance, a health IT developer requires vetting of the third-party applications before they can access the product. So this is, again, those sort of barriers that are imposed for the use of APIs. And if you find out, as the scenario describes, that there is a violation and it implicates multiple people's ability to access that API, access that data, each of those violations is going to be subject to a penalty. Next one. Now, of course, COVID has, despite the best laid plans of mice and men, thrown in a few wrenches into the implementation timeline. There has been a 6-month, extension of the timeline for implementation of these rules. So while a number of these are going to be, in effect January 1st, 2021, you're really not going to have, enforcement until earliest of July, I think, and as you can see from the timeline here, this is very much a phased approach. These rules are complex, complicated. It involves technical updates and rolling it out across health payers, it's going to be big, and it is an aggressive timeline. But sharing sort of that deadline here with you, and it covers the next 2 years. Next slide. That's not all, and Peter's going to take us to the CMS.
Yeah, so in addition, CMS in March of this year, pre the really full-blown COVID public health emergency, to Tina's point earlier, implemented some rules of their own. It came as a part of the My Health eData initiative, and it really focuses on driving that interoperability and patient access to health information in a couple of different ways. And as Tina mentioned earlier in the presentation, it's pretty specific, these sets of rules, to your public payers, your Medicare Advantage, Medicaid, CHIP, and QHPs on the federal exchange. So just real quick, what are they? The first is a patient access API. So this is the ability for patients to take data wherever they happen to go. It's their ability to go in and define what information, or have a defined set of clinical information that they can have transferred between providers, between systems at their request. The second is a provider directory API, and this is both provider and patient facing. This is public information about providers that will help patients make informed decisions about who they want for care and treatment, as well as helping clinicians find other providers in their network that are caring for their patients, or who they need to care for their patients for given specialties or services that they may not themselves offer. They're looking for a payer-to-payer data exchange, and this is going back to the US CDI data that Tina mentioned earlier. Again, at the patient's request, to take with them a more full, comprehensive suite of data elements so that patients can have more likelihood that their providers are going to know everything about them, that they're not going to have to spend time hunting down healthcare data about themselves as they go. Not only between providers, but between payers as well. So if you move insurance companies or payer networks, that information goes with you as well. Increased frequency of federal state data MMA exchanges. Right now, this happens monthly. They're going to be moving to a daily exchange. And this data is important because it helps do risk adjustment for payment for Medicare Advantage plans for those who are dual eligible between Medicare and Medicaid. It impacts enrollment into Medicare drug programs. And this also impacts the buy-in files. And this tracks how Medicaid programs supplement Medicare payments for dual eligibles, including premiums and some of the healthcare costs that dual eligibles incur. There's going to be public reporting and information blocking. So this is going to be public notification or public announcements to those providers or systems or entities that are engaged in perceived information blocking, depending upon how they report some of their interoperability practices. And this is really intended, as Tina said, to help drive some competitiveness if providers and patients see that their healthcare providers or their entities are not engaging in open information sharing. Digital contact information, this is related to the NPPES system, and it's going to be a public report out of providers who are not keeping that data up to date, so that the providers and patients may not know how to get in touch with them. To me, that seems like a pretty basic request, but apparently it doesn't happen all the time. So CMS is looking to fix that. And then the required ADT event notifications, the admissions, discharge, and transfer notification, this is supposed to be implemented within 12 months after the application of this rule. We anticipate that may get pushed back a little bit because of COVID, but it's the idea that hospitals, community hospitals, including psychiatric hospitals, are required to share electronic data notifications about their patients to other providers around their admissions, discharges, and transfers. So I think the key takeaways for these is really, it is trying to drive interoperability. It is really trying to drive patient access to certain subsets of data, including their own data and including data about their providers. And how their data is being used, ideally in a more seamless way, and how their data is being disclosed to those who are taking care of them. And it is also looking to mandate or enhance the existing ability to share data across multiple different channels, to Tina's point earlier about both individual patients and population health levels, to support the better caring of patients across payer types and across service lines.
I'm just going to not mute myself. So I'm going to skip a few slides here since I know we're running out of time, but wanting to bring this back to HIPAA. So next slide, please, Peter. this is, again, this implicates how we operate under the HIPAA regulatory framework, but I also want to hit that OCR is part of a three-pronged attack here. Similarly to the fact that ONC and CMS sort of rolled out these rules at the same time and in conjunction with each other, OCR at the same has also been issuing guidance on how information blocking by business associates like EHR and HIT vendors constitutes a HIPAA violation implicating sort of patient right of access. In 2019, they started enforcing right of access and have since instituted 8 or 9 settlement actions in that time. Really, so the Office of Civil Rights is narrowly focusing on ensuring that patients have the right to access and use their data. Now, when we talk to some of the rules, they're limited, at least ONC is, in terms of their regulatory authority. They really apply to HIT vendors that need certification. But while they can't levy fines against providers, they have unequivocally referenced that they will be referring cases to the appropriate authorities. And in many instances, that's going to be CMS for the regulations that Peter just walked us through, or OCR for violations of patient right of access. So I want to hit that this is a multi-pronged attack. They're taking it from this is systemic, and it does, even though this is not necessarily HIPAA all the way, it does implicate HIPAA practices. Next slide, please. And the next one. I just want to, in the interest of time, wanting to hit that from the very beginning, HIPAA has been about interoperability. The previous slide just sort of gave you a snapshot of the preamble of HIPAA, which stated, the objective is to make data portable, to make operations efficient. And we have gotten away from that in the past 24 years, because, in no small part because the calculation has been that the more confidence people have in the security and integrity of these data exchanges, the more likely we are going to be to engage in them. This is reflected in a quote by Senator Sheldon Whitehouse in the early 2000s, stating that until people are more confident about the security of electronic medical records, it is vitally important that we err on the side of privacy. That calculation, I think, today is changing. We are seeing the first recalibration to specifically emphasizing interoperability. Next slide. Now, to recognize this is not a perfect statute, there are legitimate concerns as to its application, and the first and foremost one is privacy protections. Critics have, legitimately stated that this can be construed as a backdoor way to invalidate privacy protections of health data, and that's correct. Patients can give their data to software app developers, and then it's no longer protected, and that is a concern. So it is important that patients be informed about who they're partnering with, the terms and conditions that they are engaging with when they allow them access to that data. We as industries and stakeholders, we're going to need to insist upon greater transparency by the Apples, by the Googles, by all of the app developers that are seeking to get into the space, to ensure that there are commensurate there's commensurate undertaking that they will protect that data, because they're not governed by HIPAA. There's also concerns about the enforcement timeline. It's been pushed back a little bit, but it is still an aggressive one, particularly when you're talking about overhauling 24 years of practice. And then, as some of the EHR vendors have indicated, sort of fairness of, overriding an existing strategic moat in their market. Next slide. So what I hope you've taken away from this discussion is that I personally, and I think Peter as well, are excited. I'm excited about these new rules. I think that this makes a more workable framework. It removes some of the freezing effect that HIPAA has had. I also think that this is absolutely necessary if we really mean what we say, that we want care to be patient-centered. That means that patients should be able to direct their own care, and we should provide them the tools to exercise that right. So I want to open it up to questions now.
We've not yet received any questions in the chat, and we are a little bit over time. So if there aren't any questions, we will conclude now. If there are, please feel free to send it in chat. If something occurs to you later today, please feel free to reach out to us by email. We're happy to answer any questions that might occur to you.
I do just want to jump in and say, I know we did receive a question prior around HIEs. So CMS's rule specifically doesn't address HIEs, and we think largely in part because of the other provisions that is put into place, the patient access to data, the data exchange between payers, the data about providers. So as of right now, at least the CMS interoperability rules don't seem to directly address HIEs, and we think those are the reasons why, but we will be keeping our eyes on that and obviously share forward information should that change or should more details emerge that actually directly impact HIEs.
Thanks, Peter. All right. Well, thank you everybody for joining us today. We really appreciate it, and we hope that you found this informative. You will receive an email within the next couple of days that includes the slides, a link to the recording, and a survey to provide feedback. So thank you again for being with us today. Thanks, Tina and Peter. We really appreciate it.
Thank you all.